Welcome to our first town hall of the year, Navigating Musculoskeletal Medical Management in the Workplace. For those I haven't met, I'm Sarah Isher, Program Lead for the National Safety Council MSD Solutions Lab. Thank you all for taking the time to join us today. We have a fantastic speaker lineup this afternoon, as well as some exciting program updates to share. Before we dive into today's program, I want to say a few words about the MSD Solutions Lab. Those of you who are familiar know by now that musculoskeletal disorders, or MSDs, aren't just one of the biggest safety challenges facing today's employees. They're also one of the biggest challenges facing today's employers. Not only do they take a physical and psychological toll on workers themselves as the second leading cause in shortening employees' working years, but MSDs are also very costly. Each year, private businesses in the United States lose a total of $17 billion in lost wages and medical expenses due to these injuries. It's for these reasons NSC, with funding and support from Amazon, has been so focused on addressing this widespread safety challenge these past couple of years. Our mission at the lab is quite simple: to eliminate MSDs from workplaces worldwide so workers can spend more time doing the things they love with the people they love. We are already making tremendous progress by engaging key stakeholders, conducting research, identifying new technology, innovating solutions, and scaling the results so all workplaces can benefit. In fact, through our Hallmark MSD Pledge program, nearly 200 of the world's leading organizations, representing more than 2.8 million employees, have joined us on this journey to transform workplace safety. With that, I want to switch gears to the rest of today's agenda and introduce our speakers. First, we're pleased to be joined by OSHA's Dr. Michael Hodgson, Chief Medical Officer and Director, to take us through today's topic, MSD medical management, in more depth. Following him, we'll have a spotlight discussion with Brian Reich, Vice President, Programs and Operations at WorkCare, on the latest advancements and best practices in MSD medical management. Roger Parker, occupational health nurse on the injury management team at Amentum, will then join both of them for a panel discussion on MSD prevention and medical management. Finally, we'll conclude with some program updates and discuss our next resource. We welcome questions from the audience, and we will do our best to get to them during today's event or in follow-up communications. If you have a question, feel free to use the Q&A feature at the bottom of your Zoom screen. To kick off our discussions, I want to welcome Dr. Michael Hodgson. Michael has been Director of the Office of Occupational Medicine and Nursing and the Chief Medical Officer at OSHA since 2013. Previously, he worked in the Veterans Health Administration, where he led the development of a national ergonomics program. Welcome, Dr. Michael Hodgson.
Thanks. So, first of all, OSHA is always privileged and pleased to be able to talk to groups of people about stuff we worry about. So thank you to NSC for the invitation. When it came in, I was a little startled by medical management because OSHA's perception have I been on?
You're good to go, Michael.
So none of that earlier stuff showed up.
We all heard you. We just didn't see you.
Oh, okay. Never clear who's running what button. Right. So the question of medical management, OSHA thinks ergonomics are managed by engineers and ergonomics program and not by medical clinical staff. But so that's not my primary purpose here. NSC asks that I address three specific things. The first being, what is it about OSHA recordables? What should people record? Who does that and how? The second being, what happens with OSHA inspections? Why do people get inspected? And then as a third, what does OSHA view as the medical management aspects? Again, OSHA as a non-clinical organization thinking about this, trying to help employers think about it. So the first question is, what are OSHA recordables and what constitutes, because it comes up all the time, medical treatment beyond first aid? OSHA has a formal 5-step process up on the web, and fundamentally, OSHA says all injuries and illnesses that are work-related and that meet certain severity criteria must lead to an incident report on the OSHA Form 300, the Injury and Illness Incident Report Form. And therefore, they must be recorded on the OSHA Form 300, that log of work-related injuries and illnesses, within 7 days. And at the end of the year, they should be included on the OSHA Form 300A, the summary of work-related illnesses and injuries with hours worked and the like, so that you can actually calculate or estimate at least a rate of things and compare them to the Bureau of Labor Statistics data. The severity criteria that make something recordable are death, obviously, days away from work or restricted work activity or job transfer, medical treatment beyond first aid, loss of consciousness, a significant injury or illness diagnosed by a physician or a professionally licensed healthcare provider. And it's important for employers to recognize that OSHA's definition of first aid for record-keeping purposes differs dramatically from that clinicians and the American Red Cross and healthcare systems use as they think about the delivery of medical care. Next slide, please. Why is that? Next slide, please. Why is that important? Well, the first aid exclusions that say you don't have to record something don't necessarily mean there isn't a disease. And we'll get to that in a minute. But the bottom line is using prescription medication at non-prescription medication strength, like Motrin 400 milligrams or less, or someone taking less than 10 days of non-steroidals, a tetanus shot, cleaning, flushing, or soaking surface wounds, wound coverings like butterfly bandages and steri strips, hot or cold therapy, ice packs, for example, non-rigid means of support, so soft splints, temporary immobilizations on the way to a hospital. So if you put someone in a boot on the way to a hospital, but in the ER, they say you don't need that, and you get sent out with an ACE bandage, that's not a recordable injury. Drilling of a fingernail or toenail to drain fluid, a hematoma. Eye patches. Removing foreign bodies using a cotton swab or irrigation, not a fixed thing. And people should know that this, cotton swab use to remove eye things is considered a no-no, meanwhile, in healthcare, has been for 15 years. But OSHA has a hard time changing its regulations. Removing splinters or foreign material from areas other than the eye by irrigation, tweezers, cotton swabs, or other simple means. If you start cutting, that makes it recordable. Finger guards, massages, and drinking fluids for heat stress. So massage, per se, is a first aid exclusion. Of course, there are many procedures that have both a massage and a physical therapy name. So deep tissue massage, for example, counts as massage, although many physical therapists consider that an essential physical therapy treatment. And drinking fluids, as soon as you start having to run IVs for people, that counts as a recordable injury in the emergency department. Next slide, please. So why does OSHA inspect facilities? What happens and what's the goal of those? So OSHA does two different kinds of site visits. It does programmed inspections and unprogrammed inspections. The programmed inspections happen when OSHA, and it tries to spend about half of its resources on inspecting work sites that meet certain criteria. They have high injury rates, they show up in the BLS, that NAICS code shows up in the Bureau of Labor Statistics data, and then we send people out to do specific evaluations after extensive outreach to that employer group to make sure they know they may be on a random inspection list. Unprogrammed inspections happen in response to complaints and referrals. So workers can file a complaint with their local OSHA office, and OSHA will call to find out what's going on. Or a physician can turn an employer into OSHA because they think there have been 3 amputations in this warehouse, in this meatpacking, section of a grocery store, and they're clearly not taking care of things. Our compliance officers go out and compare what they see to either the standards we've promulgated or to the general duty clause and decide there is either a violation or there's something that we think warrants correcting, but it doesn't rise to the level of needing a citation. We'll then send a hazard alert letter. And the general duty clause, for people who don't remember, OSHA says employers are responsible for providing a safe and healthy workplace. OSHA's perspective is that injuries are preventable. There really is no such thing as an accident. There's inadequate thinking about the workplace. And so OSHA thinks it's employers' responsibility to identify hazards, to develop programs to control those, and to, when something goes wrong, to conduct root cause analyses to understand what happened. The simple Army mode is what happened, what should have happened, why the difference, what do we do to prevent it? And there are very complex, multi-modal assessment systems. Next slide, please. So in terms of the medical management of musculoskeletal disorders, we think it's worth distinguishing what an employer has as responsibility for systems thinking and for the worksite itself. And we distinguish that from the clinician responsibilities. So when an employer sets up an implant clinic or decides they don't want a nurse or an athletic trainer or an EMT, or they don't want a long-standing emergency first aid station, they decide what staffing level they need, what scope of practice that person should have. Do they practice under somebody's authority? Do they have protocols that they work under? And is there appropriate supervision? So different professions have different licensing status, from the state license, because those state licenses differ, and the expectations, not just from the state licensing bureau, but from the National Professional Society with, for example, codes of ethics differ. The state licensing differs. The National Code of Ethics really is the same for everybody. And we may talk more about that later. But the bottom line, in healthcare systems, the individual practitioners have complex systems, referral pathways, and there's a formal way of dealing with quality management that often doesn't exist with employer in-house programs. So when an employer sets up something in the work site, there's a recognition that some set of symptoms probably should lead to some assessment of the workplace, work site, work process that may have led to a problem, and review the work practices and the setup. That may lead to modifications. We think of that as engineering controls in the hierarchy of controls as the primary intervention. There are sometimes other assignment changes, restriction, for example, hours with rotation, transfer to a different job, or days away. Next slide. From a clinician perspective, there's a very different set of considerations. When a patient walks into a clinician's office, whether that's a DO, an MD, an NP, or depending on the protocol, a registered nurse or a licensed practical nurse may actually do the initial intake. Those symptoms become a syndrome or a diagnosis by the description of the professional with the appropriate skill and scope of practice. And they then recognize the recommended treatments that often have national guidelines with national protocols, including recommended, management at work and estimated duration of disability. So, for example, if you have tennis elbow or golfer's elbow, the range of time that you may not be able to use that is likely 6 months to a year. So, knowing the national practice guidelines is a critical thing. And understanding the scope of practice of the clinicians is critical because many people sitting in a plant dispensary do not have, from our experience, do not have adequate guidance. They have not been credentialed in the way that same profession is credentialed in a healthcare system, and often the skills they have differ dramatically. So, for example, in my office here, we have 6 physicians, 2 nurse practitioners, and some other staff. Not all the physicians have the same skills. Not the 2 nurse practitioners have very different skills. And primary care practice in a plant dispensary may require a very well-defined protocol. And we've seen them in large systems with 80 and 100 pages and annual review. And it's worth thinking carefully how those happen. And if you don't have those, making sure you have a good relationship with a local healthcare provider. So I've talked about record keeping, what you can expect from and why you get OSHA inspections, and what OSHA views as medical management. Thanks.
Thank you so much, Michael, for taking us on a deeper dive into MSD medical management through the lens of OSHA. We appreciate your insights and experience. So now for our MSD Pledge Member Spotlight, this will focus on MSD-specific medical management. I'd like to introduce Brian Reich, the Vice President, Programs and Operations for Prevention Services at WorkCare, Inc., a U.S.-based occupational health, wellness, and absence management company. At WorkCare, Brian focuses on deploying a professional team of specialists who deliver industry-leading ergonomics and musculoskeletal injury prevention solutions to client companies with at-risk employees. Welcome, Brian.
Thank you so much, Sarah. So let's dive right in and talk a little bit about work hardening and return to work programs. There's a long history about work hardening or return to work, and some of it you could even attribute all the way back to the early 20s. If you look at the research around Radio Tizo, a program that started in Japan, where they said, for our health and wellness, we should do calisthenics. We should warm up every day as a culture. That then went into the workplace, and there was a delay due to World War I and II, but came back very quickly after World War II and actually encouraged people twice a day, 6:30 a.m., 3 p.m. every day, to do calisthenics. And some of the research shows that's part of why there's such a long life expectancy for the culture in Japan. And it's a major contributing factor also when they look at the lower musculoskeletal injury work rate coming out of manufacturing in Japan. So when we look at pre-shift work hardening and training, we apply some sports medicine concepts. There's not a lot of research that's been done in the industrial space on how to warm up your body for work and the validity of those programs. But when you look in the sports medicine world, you do see a lot of validity to warming up, getting your body ready for the job, and getting prepared for the job. So much so that some of the research is focused in the industrial setting on the benefits of strength training for low back pain in the industrial setting. So we know that movement is important regardless of your job type. And we know that work hardening can help with that if we make it part of our training process. And I'll talk a little bit later about the results of adding those programs. If you go to the next slide, we'll talk a little bit about the traditional training. When an employee comes on board, typically you see some training on PPE and general safety within the plant. This is where you walk, this is what you wear. Then you start talking about the tasks. this is going to be your job at this site. This is going to be your responsibilities. This is what we need you to do. Maybe there's some supervision of a senior employee of some of the hands-on process and the work that's being done. They sit through their safety training videos. They do all their employee HR training. Maybe there's some focus on ergonomics. It depends on how mature your program is. But typically, I see very little specific ergonomic training or work hardening training. And there's very little education on your overall fitness and wellness for the job. And we have some very physically demanding jobs out there. I've spent a lot of time across the country in different forms of manufacturing and seen those physical demands in action. And it can be very significant for an employee. So one of the ways we can think about practical training solutions, which is our next slide, is really identifying what the needs are of that job. So we need to take the time to dive into what the job demands are. And sometimes that takes some external consulting, getting somebody that can do a job demand analysis for you to truly understand the physical demands of the job, measuring the forces, looking at the repetitions, the impact, and the fatigue to the human body. We need to maybe leverage some technology that's out there. We know there's a lot of AI motion technology, wearable sensors that are out there that can help us get some objective information, but you also need the subjective data from the employee of how they feel. When we analyze the injury data, we're looking at those lagging indicators, but we can use that technology to look at leading indicators. When we put those together, we can really truly identify the total need for each job. It takes a lot of collaboration across your teams. It takes HR, benefits, and everyone working together to develop this process of work hardening. And when you develop your training, you need to look at how do we prevent the injury to begin with? How do we engineer out the risks? We do that when we design a facility. How can we do that with engineering the risk out of the job for those individual workers we're bringing on board? You want to look at the total worker health benefits and really engage the EHS team that's on the floor, boots on the ground, with the employees that have done the job, that are seasoned, to develop those solutions. Have a progression in mind for your employees. When we look at return to work programs, we need to look at our aging workforce, and we may talk more about that later in our discussion, but we need to have a way to take our legacy employees and keep their knowledge within the organization, but have steps to promote them. We want to facilitate transition and job rotation from one job to another and really establish a check-in process with the supervisors. Focus on, hey, how do we check in on the progress of this employee as they've come on board? How do we develop this program that can harden them to this job so they can successfully complete this job for the long term? And we want to have a dedicated plan around following up. So we need to know those ergonomic principles at every level: the supervisors, the safety professionals, middle management, plant management, the engineers should know some of those ergonomic principles that are guiding why we're putting this type of program in place. And then we need to get employees' feedback on this and continually iterate and improve the program as we move forward. So let's look at this different plan for return to work on the next slide. It's a little non-traditional. It means that we need to take work hardening seriously and say, here's the demands of the job. There's significant demands, physical demands to this job. It stresses your shoulders. It stresses your back. It stresses your legs. Let's actually build a plan to help those employees develop their body, their physical skills, and their mental health and mental skills as we move them into this new position. And so that may be developing things like a candidate prep guide to educate the employees on what the demands of the job are. It might be making sure that when we look at return to work programs, we look at the full clearances that have been given by the physician, and we say, oh, this employee is ready to come back. But oftentimes that employee has some nervousness or some tentativeness around coming back to work. We see it in the sports world where athletes are nervous to return to work because of a physical injury, and they say to themselves, I'm not sure if I can do this anymore. I'm not sure if I'm going to get hurt again. I actually have a fear of getting hurt again, and I want to be able to play with my grandkids. So this is going to be a challenge if I come back to work too early. And so if we go through those previous steps of getting really solid job demands developed, understanding the risk to the job, and then developing programs of training that are progressive, it will prepare them for that. And then when it comes to returning, our supervisors and fellow employees need to think about that employee as they return and how to take care for their mindfulness and their mental health as they come back. We need to adapt our programs to make sure that employee returns safely. And we can avoid the unintended consequences of somebody getting hurt again by taking these steps. If somebody does too much too soon as they return, and oftentimes those physicians are returning employees too soon because they don't have the full job demands. We have job descriptions that might be the same job description for 20 different jobs, or a job description that not all the demands have been updated. If we look at the next slide, some of the challenges to developing a work hardening and return to work program that look like this means there's going to be a longer training process. It's going to be challenging to execute this across a whole organization if you have a lot of different job types. It requires support from benefits and HR and safety all working together, and possibly additional information. And it requires internal champions to really push things forward. If we look at this program, I want to talk about the results. So if we jump to the next slide, what do people see when programs like this are deployed? I want to start with some subjective feedback before we get to the objective. When we deploy programs like this, employees feel like they're cared about. They seem happier at work. This is what supervisors say. They see that their employees feel like they're cared about because extra steps are being taken, not only in the training process, but also in the return to work process. And if we look at a case study, looking at the next example, I saw this in a utility setting. We developed a candidate prep guide. We had very specific job demands. We had a full day of new hire training dedicated to educating them on ergonomics and health and wellness. We had legacy employees providing input on that training and helping train the new hires coming in. There was a progressive new hire supervised work program where the work progressively got harder and harder as an apprenticeship. We had injury prevention specialists coaching employees on site, and we had high levels of return to work engagement. We also had a very great post-offer physical assessment program that was very job specific and third-party validated. What we saw when we deployed this on the next slide, the results was when we had a return to work and work hardening program built that provided this level of training, we took a look back, and once we deployed this kind of program, the new hire MSD injuries went to almost zero in one category because we were providing this type of program. They saw a significant decrease in recordable musculoskeletal injury, and they saw a compensable claim decrease, as well as workers' compensation costs went down, cost per claim, as well as severe injuries went down significantly. So we know that when we implement programs like this, although it takes a long time to develop, we can have significant results, both anecdotally and objectively. And with that, I think I'm going to kick it back over to Sarah to lead us into our panel discussion.
Thank you, Brian, for telling us more about practical training and return to work solutions. We appreciate your insights and experience, but don't go anywhere quite yet. For our next conversation, I'm excited to bring back Michael and introduce Roger Parker from Momentum. Roger has been a registered nurse for 33 years, and he started with Momentum in 2016. Prior to that, he worked in the long-term care industry and consulting for 17 years. After high school, he joined the U.S. Navy and was a hospital corpsman. This experience shaped the foundation of his healthcare career. All three of the panelists are experts in healthcare and ergonomics in a variety of sectors, so let's dive right in. So Michael, we understand that employers can use OSHA 300 logs as a guide to track workplace hazards. But what other data or metrics should employers consider monitoring for hazard mitigation? Oh, you're on mute. There you go.
Yeah, so trying to which button where and when can
I understand.
So Yes, employers can use the 300 log as a guide, but um, it's a great place to start, but by itself doesn't do much good. The OSHA Form 300, the detailed description of injury, if employers are actually using that, is much more useful. And OSHA separately has a tool along the lines that Brian described for the identification of hazards that NSC may put up to help people look. But rather than looking at the the 300 log and 301, there are very formal root cause analysis systems that explore what happened, what should have happened, why the difference, and how to prevent that in the future. And they drive down to the why question. Why did this happen? The frequently used 5 whys that gets you somewhere is one great tool, but it leads to one specific thing based on each question you ask, rather than recognizing that there may be a lot of different things that come together, because most adverse events are what safety specialists call overdetermined. They have a combination of things leading to the outcome, the Swiss cheese model of adverse events that was popularized in patient safety. So equipment, training, culture, and well, yeah. So that's the one thing. The problem is that all of these are lagging indicators. And Brian has used the term leading indicators for the first time here. And I think that specifically in MSDs is a critical issue. How do you identify the things that lead to reduction in the hazards that lead to events? So again, OSHA has a recommended practices guide that I hope NSC will put up later. There are formal ways to do a job hazard analysis by the employer without hiring outside, um, you know, people with skills that will at least get them started. Again, an OSHA worksheet on how to do a simplified version of that. But those are two kinds of indicators that go beyond the 300 log.
Okay, thank you so much, Michael. And Roger, beyond metrics, what does successful involvement between employers, healthcare providers, and employees look like in this MSD medical management process?
Thank you, Sarah. Amentum signed the National Safety Council's MSD pledge in 2022, committing to reduce the musculoskeletal disorders caused by ergonomic hazards by 25% by the year 2025 from our baseline in 2022. We started with ergonomics awareness and training as part of our site safety training programs. Having an effective injury management process is one of the keys to our success at Amentum. Excuse me, our program is especially effective for larger companies. However, if it's scaled down just a bit, it could work for a small company as well. Basically how it works is all work-related injuries are reported to the injury management team via a 24/7 hotline. We triage each injury and determine the right course of treatment and individualize that care. We call it the right care at the right time. If it's a first aid injury, we treat telephonically and complete subsequent follow-ups if needed. But if we do have to triage them out to a higher level of care, we do that as well. We have a medical consult team of physicians at WorkCare. Thanks, Brian. And we also have telemed physicians available through WorkCare. And that's available in a select few states across the U.S. The injury management hotline can also be used as early intervention for MSD injuries. Our ability to provide medical advice to our employees directly allows them to call us for aches, pain, soreness, etc. And then we can recommend some first aid recommendations for that. Muscle rubs, over-the-counter anti-inflammatories, things like that, to help prevent progression of a more long-term MSD. If a higher level of care is warranted, we are very involved in that as well. including communications with boots on the ground, safety managers or managers, clinicians, ER physicians, nurses, but most importantly, the employee. We follow the injury through the entire process of care. We have in-house claims management teams to ensure that the employee is returned to work to their highest level of care possible. Our injury management hotline nurses follow up on medical information from clinics to ensure our employees work within the restrictions that they've been given. If they have any concerns or if they need follow-up appointments, we also help with that because they can call the 24-hour hotline anytime. And lastly, I just want to say that we work very hard to accommodate all work restrictions. The nurses facilitate information exchange between the employees, medical professions, the employers to ensure that the work restrictions are accommodated and allowing the employee to continue to be active and working during their injury without working outside of their restrictions.
Thanks, Roger. I really like hearing about how you involved all levels throughout this medical management process. So Brian, kind of switching gears a little bit, who are all the stakeholders within a company that can support an employee's successful return to work following an injury, and what roles do they play?
Yeah, so there is a lot of stakeholders within any company that need to help support employees return to work, right? You've got your benefits department with risks management and potentially your workers' comp department that are really going to drive that when they are out on work, right? And appropriately getting care at the right time, as Roger mentioned, in the right place, right? Making sure they're getting to their appointments. But as they come out of that process, your safety and plant management should have those accurate job descriptions ahead of time so that the doctors know when they can clear them from a return to work. The safety team should be working in partnership with the supervisors as they're coming into return to work to help observe and support making sure that employee is working safely. And that they're healthy enough following that return to work clearance to really do a physically demanding job. And then you may have somebody on site like an ergonomist or an injury prevention specialist from my department, my industrial athlete department, or the fellow employees all coming alongside and supporting that employee to make sure that both mentally and physically they're ready to come back. So following an injury, each member within an organization has a role to play. It's how are we building those cross-functional teams to work together to make sure at the end of the day that employee is coming back to work healthy and safe.
Yeah, and I like how on your response, you really touched on the physical and mental aspect of this. So Michael, this kind of comes to the next question to you. How can companies implement best practices that support a safe culture of early reporting for these types of injuries?
It's a great question and a huge topic across the country. In every company, leadership sets the tone for an organizational culture that is supportive of safety or not. Safety as a core value has been around as a battle cry in the safety world, certainly for 25 years. So building trust and respect by identifying strategies to meaningfully and proactively engage workers in safety and health, creating transparency and feedback loops, who listens to the plant nurse who's heard about something by responding and fixing, and ensuring there's recognition, not retaliation, for people who report incidents and near misses. OSHA has a thing called its Safe and Sound campaign, now in its 7th or 8th year, and there's a safety and health program step-by-step guide to help employers as they try and implement that. So again, there's a Safe and Sound, if you type OSHA and Safe and Sound campaign into your search bar, there's a toolkit, there's a step-by-step guide to help employers implement a comprehensive safety and health program and culture. Again, if you type step-by-step guide and OSHA in, you wind up getting that kind of tool kit. But that's really that's what they can do. They can also just prevent all these by paying attention.
By listening to the employee, right? Keeping
And
centered
to
in
what
we do.
and what the Ryans of this world have been telling them.
Yeah. So, Brian, as we talked about, culture is key throughout this medical management process. So, can you tell us about the role of psychological safety and mental well-being in return to work? And why are psychosocial factors so important to consider?
Yeah, so I touched briefly on it in the presentation, but mindfulness and mental health, people feeling that they are going to be safe as they return to work, is critical. And I think we saw this during COVID in a big way. Is it safe for me to come to work or not? Am I going to get sick? Am I going to be out? And that constant questioning inside their mind affects a lot more than just their physical health. All of a sudden, it affects their safety, right? If I'm constantly thinking about whether I'm going to be safe or not because of a musculoskeletal discomfort or because of COVID or whatever it may be, I'm distracted. And a distracted worker can lead to poor ergonomic body positioning, can lead to, hey, I forgot to put my hard hat on. I didn't put my safety glasses on. I didn't take that extra step to own my own safety, even though the mental issue was, I'm concerned about my safety. And so really helping that employee be confident that we've done the work to make sure that not only your job description is accurate, the doctor knows the demands of your job, and the doctor is competent to know it's safe to come back to work. You can trust that decision. But having, whether it's that reassurance from an injury prevention specialist or an on-site nurse or that safety professional that has the knowledge, or your ergonomist that's on site, to come alongside and say, hey, we're here to make sure this is safe for you. If you feel like you can't do the job, let's make sure you have the appropriate things you can do at the job, the adjusted work, the alternative work activities available to you to make sure that you build back, or have that work hardening program as part of your return to work. Hey, you can come back and slowly progress into the job so that you know that it's safe and you have that confidence that I know I can do this safely. And that will build that culture and help contribute to that culture of, my company cares about me and they want to make sure that I can do the things I love to do outside of work just as much as I do the things at work.
Yeah, that's great. Beyond that, really honing in on mental well-being, are there any other steps that employers can take to help support this as employees are returning to work?
Yeah, I think really having a connection between your return to work group and making sure your benefits provide mindfulness and mental health support, that you have a great EAP program, but also that you start removing the stigma within your work culture of engaging with that EAP program. I'll give you an example. I remember an employee that used to come to work and slam their door every day when they came to work. And there was a supervisor that had a window that faced that parking lot and said, I'm concerned he's slamming his door. He seems okay when he comes in, though. I'm going to take that step to remove the stigma and ask him if he's okay. So they called the employee in and he said, all the wind bent the hinges on my door. And if I don't slam it, it won't shut and I can't lock my car. So, there was a reason for it. But that supervisor was empowered because they were removing the stigma and engaging the other groups and talking about mental health and mindfulness and its importance to overall total worker health, that made an impact for that employee. And that employee then knew his supervisor cared about him. And he goes, hey, I feel more comfortable coming to you if I did have an issue because you engaged me that way.
Yeah, I really appreciate that. So, Roger, switching gears, as an in-house healthcare provider at Amentum, you have an opportunity to shape and inform your company's overall culture of safety. So what would you describe as the other advantages of hiring an in-house healthcare provider?
Good question. There's so many advantages of having an in-house healthcare provider. For me, one of the best reasons is employee engagement with the Amentum clinical team. Accidents are scary, and having a calm person on the phone with them to talk about their fears or coach them on their path to recovery is the reward. In a lot of companies, the employee is injured, they're sent to a clinic or emergency room on their own without any company support, and that can be quite scary. So nurses can provide actual medical advice at the time of injury, which is something that technically cannot be provided by supervisors or safety managers. Although those individuals may likely be first aid trained, they're not able to give medical advice. In addition to calming the injured employee, the ability to provide immediate medical attention without a supervisor or manager having to make those decisions to send the employee to a clinic saves valuable time, during which an MSD can be exacerbated. And lastly, I'd say a very important benefit of having an exclusive injury management process is twofold. One, the company's ability to greatly lessen the cost of an injury, and two, getting the employee back to their baseline level of functioning sooner than later.
Yeah, so that might work. We might have people that say that will work for large organizations, but for small businesses that can't afford an in-house provider, what steps can they take to maximize their collaboration with external providers?
Great question. If a company is too small to afford an in-house provider, I would suggest starting small and growing upon their needs. Having an assigned person such as an HR rep, a safety member, or a manager assigned as maybe an injury liaison, this person could be the point of contact for injuries, clinics, providers, etc. Train the trainer programs from external sources work well for smaller companies wishing to expand their injury management process. The American Red Cross offers basic emergency and CPR training. That's highly recommended. Get the employees to buy in on site safety programs by promoting their involvement in an emergency response team with basic training that can be provided at a minimal cost. And I guess finally, I'd say having a team of trained first aid volunteers or encouraging all supervisors and leads to complete first aid training would be very beneficial, since they are most likely to be the first person on the scene of the injury.
Yeah, that's great. Really leading by example with how we come to our employees. So Brian, at Work Care, you specialize in work hardening for the aging workforce, which you talked about. But what are some of the unique ways employers can support and protect aging workers on the job? And also, how do we ensure that this really kind of takes a total worker health approach?
Yeah, absolutely. I think, really understanding those job demands is critical. Michael mentioned, getting an understanding, using the basic tool of understanding job risk that OSHA already provides. But you have to understand the physical demands that are being put on your body and how that changes over time. At the age of 30, our bones start breaking down unless we provide resistance to them. As we get older beyond that, we start having what's called sarcopenia, where your muscles start getting smaller, right? And so, we have to know how to combat that. So some of the things we can do is provide wellness education to our aging workforce that's readily available to understand how do you take care of your body, how to, our changing body, you give that in health class in high school, but then you don't learn about your changing body when you hit 30, 40, 50, 60, 70, right? So provide some of that health education where it's readily available to understand that. But then as an organization, understand the job demands and understand, can somebody physically capably do this job at this age? Do we have a path of promotion so that we maintain that institutional knowledge, but maybe it's not as physically demanding work that's still continued on site? So often I hear people saying, I don't want to be promoted because I get paid more to work hard versus my supervisor gets paid less, but they're not working as physically hard. But I have more knowledge than he does. I've been at the company 37 years and my supervisor's been here a year. So it's really interesting to see some of those dynamics, and that has to be worked out at every level of an organization, right? Your senior leadership has to make those paths available and have a business plan for that. But recently, I heard a story about a 90-year-old soccer player in the UK that was probably moving better than I do, right? I used to work at a utility where I had a lineman that was teaching the apprentices that was 72 years old, and he could climb a pole like nobody's business. So if you take care of this machine that is your body and put the right things in it and take care of it, it will continue to work for you for years. But if we don't provide that education to our employees, I think we're actually doing them a disservice.
Yeah, I completely agree. So for all of you, we have a question. For those in the audience just getting started, what would you identify as the #1 key action that employers can take to support the medical management of MSDs? And Roger, I want to start with you.
Okay, great question. What I'd say the best starting point would be the amazing and free educational resources on the National Safety Council's website. That's where I started. The MSD Solutions Lab and the Pledge Toolkits offer many ways to build and discuss MSD prevention and medical management of MSDs. Spreading awareness site-wide about the symptoms, what to look for, early intervention signs, numbness, tingling, weakness, and creating a culture wherein the employee feels comfortable reporting these early warning signs. These tools and many others on the website can help build a workplace culture of safety from the ground floor. And lastly, remember that safety is a company-wide effort. It's not just the responsibility of one person that's assigned to the safety team, it's everybody.
Yeah, and I really appreciate you giving the plug for the Solutions Lab. It's good to know that our resources are being used. Great. So Michael, what do you think is one way or one key action that employers can take to get started on this medical management process?
And I should apologize. I finally found the box and I've been trying to answer questions. So I
saw you working away over there, so thank you.
But I think, designing workstations and processes to prevent musculoskeletal disorders is the critical step. So walking around, listening to people, seeing who looks uncomfortable as they're doing stuff is generally the best way to figure this out. I
agree. And Brian, what do you think is the #1 key action that employers can take?
Yeah, I think the #1 key action employers can take, and this will actually address a question that came up in the chat. First, you have to start with any MSD hazard with the hierarchy of controls and engineering out the risk. That's maybe assumed, but not talked about as much in this particular presentation. I think the #1 thing we can do is make sure that there's hazard reduction in place for musculoskeletal injury, right? Use the hierarchy of controls, engineer out the risk. Then the next step is, okay, we've engineered out the risk as much as we can. What can we look at from a total worker health model? Getting everybody together and having those discussions. So designing these programs is really the next thing. And it takes a collaborative effort from your occupational health physicians. It takes your ergonomists that have worked on engineering out the risk. It takes your safety team actually working cross-functionally. And we did it during COVID, right? Pandemic happens, everybody get together. How do we solve this complex problem? What are all the things we can do? Can we use mitigations in place? How are we going to put these mitigations into place to engineer out risk of spreading this disease? And then, okay, what do we need to consider from every other aspect of total worker health? Their physical, their mental, their financial, from being out of work for so long. How can we work as a cross-functional team to solve these problems? And I think that's something that we lost as we went into our own highly polished cylinders of excellence after COVID. And so I think we need to really get that back.
So getting back to metrics, I'm going to take one Q&A from the audience, and then we'll have to move on because we're a little short on time. But getting back to metrics and how do we actually understand if what we're doing is successful? There's definitions on leading indicators that are fairly broad and sometimes feel kind of vague. So can you give some tactical examples of leading indicators in practice for MSD prevention? Anyone want to take that?
Yeah, I'll just jump in real quick on a couple of leading indicators that we look at. How many preventative engagements are you having with your employees regarding musculoskeletal? How many ergonomic coaching sessions are you having with them? How much training are you providing them related to, reducing musculoskeletal risk? Those are some leading indicators. The one thing I want to focus on, though, is your leaders say they want to see leading indicators, but what do they look at most of the time? The lagging indicators. So you have to have agreement from your leadership on what those leading indicators are that you want to measure and how to measure it and what that outcome looks like. Because we do mention leading indicators and it is a buzzword, right? It gets thrown around a lot. So you want those practical examples. Hey, trainings, engagements in preventative activities, those are great leading indicators. But do you have a way to measure it? Is it a SMART goal? Is it, specific, measurable, actionable? Can you put value to it? If you can, then your leaders want to see it instead of just, hey, how do we do on our recordability this year?
Yep. Thank you, Brian. And I see, Michael, you have your hand up.
Yeah, I wondered whether, although I don't disagree with anything Brian has said, it strikes me that listening to the workers doing the jobs is the critical thing to figure out what's going on. And you can get there in one of a number of ways. You can have, groups of workers who sit around talking about their job. There are all kinds of, non-union workplaces that have meetings at the beginning of the day or at lunch with and without a supervisor, at which people say, this hurts or that hurts. And so making sure that people talk about their job in a way that is safe and that they can raise that to management so that interventions can happen early before, people have to go see.
Right. Really closing that feedback loop so that way we don't have to worry about getting them to return to work, but we're removing that hazard altogether.
And then there are issues like preventive maintenance in the machines.
Right.
If you don't have a PM program that keeps your pulleys tight and your bearings greased, and it's really got to be designed for the specific workplace. And so that OSHA guide walks people through some things. It's a generic thing. So an employer then has to think about what are the things that could go wrong, that could add workload,
right,
and that could require increased force, or do you have to hit something 2 or 3 times rather than once? So it's a matter of looking locally at all of the things that can go wrong, figuring out whether you have a way of estimating when what's going to go wrong, and counting whether you're actually doing what you had laid out.
Yeah. Well, I appreciate that so much. Thank you, Dr. Hodgson, Brian, and Roger for your insight and the in-depth discussion about MSD medical management. So by now you've heard that MSD prevention should be a core focus for every industry and every manager. But when MSD injuries unfortunately do occur, it's critical to understand effective measures and best practices to reduce their severity. To that end, the Solutions Lab is working on several resources to help organizations with MSD medical management. This includes a guide and a flowchart series on the medical management decision tree, so stay tuned. Lastly, we're in the process of creating a case study with Schneider Electric about their organization's use of injury prevention specialists to mitigate MSDs. We're pleased to share this will be published soon, but here's a sneak peek. So keep an eye out for all these new resources to help you address this critical safety challenge that we discussed today. Before we close out today's program, I want to say a few more words about what's ahead for the MSD Solutions Lab. In the next few weeks, we are looking forward to publishing the lab's third white paper, which focuses on evaluating the correlation between DE&I and MSDs, and really addresses key safety culture concerns today's employers may have. We're also continuing to advance pioneering research and innovation through our 2024 Research to Solutions and pilot grant programs, which were announced in January, so stay tuned for those. Lastly, this June, during National Safety Month, will mark the 2nd anniversary of the MSD Pledge with another installment of our Workplace Safety Series. We are inviting folks to pre-register for the June Workplace Safety Summit. If you would like us to pre-register you, please select yes in the poll on your screen. And as we finish today's town hall, I also want to encourage anyone that has not yet joined the Pledge community to sign the MSD Pledge 2.0. It really doesn't matter if you have a 25% reduction goal or a 1% target. Our charge of the MSD Solutions Lab is to empower any organization committed to safety progress to join us. It's through the collective efforts of all of us that we'll be one step closer to achieving our vision of a world where all workplaces are free from MSDs and workers can live their fullest lives. Thank you again, everyone, for attending today's town hall, and have a safe rest of your day. We'll see you again soon, and as always, be safe.